All right, thank you. Thank the panel members for their talks. Let me just remind the roundtable members to identify yourself, name and affiliation, and to the extent that you can be brief, we will actually allow for audience participation. Beyond the roundtable, Cindy, let's start with you.
Cindy Brock, Agency for Healthcare Research and Quality. I think it's really important that we be clear to distinguish between a discharge summary and a discharge plan or discharge instructions. So the discharge summary is what goes to the clinician who is taking the patient after the discharge. The discharge plan or instructions are for the patient to take home. And Avinal, some of your comments sort of confused me in terms of it sounded like you were really talking about things required for the discharge summary that are not necessarily what we would want patients to have. And I think that we really want to focus our conversation here thinking about what are those consumer facing instructions. I also agree that when you said it's often not impossible to make the IT do certain things that it may be resistant to do, but a lot of that has to do with what the priority is in the IT department as to whether or not this gets done in a year or 7 years or not at all. I have to take issue with the suggestion to leave the boost type or red type after hospital care plans separate because we actually had a demonstration with a number of hospitals around the country doing the re-engineered discharge. One of them decided to, bite the bullet and integrate it fully into their EHR, and it took a better part of a year, but they managed to do that, which also begs the question of if it's regulations and guidelines that are driving, why is it that some hospitals are able to use streamlined discharge instructions and the other ones are saying, well, no, the regs make us do these horrible things.
Concise.
Yes. Okay. Andrew was, yeah, no. Good. All right. Mark, I want to do a check back. I thought you said that there was a study that showed that the complexity of discharge instructions did not affect outcomes, and therefore your takeaway was we need to target. Did I understand that correctly? And how do you reconcile that with universal precautions?
So first, thanks for your comments. I completely agree with you about integrating this into the electronic medical record. I think this is absolutely essential. We've got to think about care providers' workflow and what they're doing and can't expect them to do extra things. So this was the study with Eric. We interviewed 200 plus people and then followed them into their homes. And it just seemed like whether they had multiple issues going on, or just a couple, it didn't impact how well they understood things. It was more related to their health literacy skills and their cognition. Now, maybe if we had 1,000 patients in the study, that might have changed things.
But I thought it was the complexity of their condition and the complexity of the discharge instructions. Did I misunderstand that?
Yeah, so those points. And
Okay.
it's the patient's capabilities. I think if you go back to the theoretical framework, it's what is the patient able to bring to the understanding as they navigate this care transition, if you will. So, and I think a lot of this relates to the comments that Bernard had brought up around information overload and how we manage this and the contacts and follow-up. And I think this is where Coleman and Naylor's approaches basically and forgive me for saying this, but they provide a Band-Aid on a broken system because our system isn't adequately providing the information to the patients in an understandable manner and allowing them to reconnect with their appropriate medical homes and so forth soon after hospital discharge. And so we have to have these navigators because the system is so complex and dysfunctional. And I better stop because I'll keep going myself for a long time.
All right, great, thanks. Winston, let's go to you.
Thank you.
Oh, okay.
Missed you. Go ahead,
You have
Dr.
some
Ing.
specific questions for me, right? And I'll try to keep it brief. I only have 60 minutes to answer, correct?
You tried that before.
Yeah, it didn't work
Didn't
then
work.
either.
So I just want to clarify, my concern with having those documents outside of the EHR is not to segregate them from the flow of information. It is because in my experience, once you start putting things and asking the EHR to take care of it, you try to automate it. And then instead of these fields where the provider would sit down and say, this was your problem, this is the common word, you'll end up with find where in what we already did in the EHR we can pull that piece of information and stick it onto that form, and create a table of definitions and stick it into the what does that really mean, and you'll have mismatches and more confusing information. And that's what I wanted to get away with, was preventing something that excuse me, that could be an opportunity for provider-patient interaction and turning it into just another item that the EHR spits out. So I want to be clear on that. The other is, can you clarify what do you think I was saying is part of the discharge summary rather than the instructions? Because that's my fear, is that there's plenty of stuff that should be in the provider to provider, that now things are being driven towards provider to patient. And part of that is there are state-specific regulations, which may be why some places are easier than the other. And the other is this interpretive dance that Mark talked about, where because one hospital was bit hard by the JACO auditors, they're now going to put in the kitchen sink, whereas another hospital is willing to do a little bit more, less is more.
Thank you. Winston Wong, Kaiser Permanente, member of the Roundtable. So, and this may be off of some of the remarks that Cindy just made, but one thing about the presentations that I didn't hear so much is really going back to this patient-centeredness concept. It seemed to me that a lot of the discussion was can we assure that our patients are better receptors of the information we give them, as opposed to posing the question is what is important to the patient in terms of their return back to home, and what are they trying to achieve, and what are they unsure about as they return to home. And I think even Dr. Dreyer's remark with regards to the fact that teach back is not used generally throughout our healthcare system, there's certainly not a lot of teach back with regards to physicians and other medical providers reflecting back to the patient in terms of what do I understand, what is important to you as you return back to home, what are the things that you're unsure about, and what things can we help you with. And I was wondering if you could respond to how you would input more of a patient-centeredness aspect into kind of the discharge format.
I think that's a great point that you bring up. I actually wanted to emphasize, I think teach back right now is almost like a raging fire crossing the country as far as uptake finally after all these years. Project Reengineering Discharge emphasizes this. IHI's initiative around reducing readmissions emphasizes this. It's a critical element of Boost, though interestingly it was a bit of an afterthought as we were developing the toolkit, and immediately the hospitals with whom we interacted said this is great and became the most important aspect in a way of what we teach hospitals as we implement this. The reason for it? Patient satisfaction being included in value-based purchasing as a component so hospitals can make more money if they have high patient satisfaction scores, and recognizing that if you pay attention to the patients and help them understand what they're supposed to know, they're going to check that off on the patient satisfaction or HCAHPS survey. Kind of it was a fascinating thing that happened. But I think you're right that as part of our instruction to nurses and physicians and pharmacists and therapists and so forth that interact with patients, they need to begin their conversations with them, and it's something I think is being taught more and more in schools, of identifying what's important to the patient and what do they perceive as going on as the cause of their issues. I do this now. I'm always fascinated by what patients tell me, and if I don't know what they're thinking, then a lot of my conversation is wasted because I've not addressed their concerns up front.
Just briefly, I don't have that much more to add to that. I just want to say I completely agree that it's important. I think that was part of what I was trying to get at in thinking about what they want to know about their prognosis. And, you know, you can broaden that to say what do they want to know, what do they feel they need to know, and to address that as part of discharge planning. So, a very good point.
Yeah, I just want to say something briefly about that as well, that at our hospital, we have a very active family committee where we have patient representatives, who's really the parents and family. And so thinking about processes to improve communication, particularly around discharge, we actually went to that group and said, well, we're thinking of bringing in technology to help parents understand different components around discharge. You know, what do you think about that? And the feedback that was received was, well, that's great, but what we really would rather value is really the interactions that the care providers are going to have with the patients and families, and that the technology really should perhaps be peripheral to that. So engaging and involving patients and families is really very key.
Bernard, quick. Oh.
Just, I forgot to mention one thing. I just want to get back to Rima's comment previously about pilot testing. We have found that using pilot testing really gets at that issue of what patients need to know, want to know, what their perspective is. And that is actually the best way of actually understanding and on building a process, understanding how to do that. So I just want to give Rima a shout out about that, because I do think we almost never, the healthcare system, for a variety of reasons, as was mentioned earlier, almost never uses it. But every time we always use it in developing these tools, and that asthma action plan has been pilot tested with patients back and forth before most of the time was pilot testing with patients. So I do think that gets at their point of view.
Go ahead, quickly.
I'm just going to take a second to thank you for that, but also to highlight the fact that pilot testing ought not to be something that is done or not done on a casual basis. It is part of the absolute scientific rigor of formative evaluation. And to the extent that people make excuses, oh, we don't have the money, we don't have the time, it is too, that is totally unscientific and is ethically irresponsible. So that pilot testing is not casual. It is something that we do not allow a drug on the market without it being carefully tested. We have to be the same with any materials and any information that we offer. So again, it's not a casual issue, but thank you for highlighting that, Bernard. I really appreciate it.
Did you guys do the $5 exchange for that? Just out of curiosity.
I cost more than
No.
$5.
Yeah, sorry. You know, I work at a nonprofit. Terry Ann.
Hi, thank you all for your presentation. Terry Parnell, North Shore LAJ Health System Roundtable member, sorry. Dr. Dreyer, I was just thinking about your comment where you say everybody has a smartphone, and that keeps resonating with me, and I agree, I find that as well. I'm wondering if, in your experience, or what your thoughts are on utilizing texting. You know, when you talk about unfinished business, it always amazes me how I could call people, leave messages, they never call back, but I text them, and within 10 seconds I get a response. And secondly, do you have any thoughts or experience on audio or video recording the discharge process? I can think of two initiatives right now in our health system. One, they're video recording the process, and then another, it's just the verbal instructions, and sending that as a link to the patient and to anyone else they want. It could be their daughter out of state, or another caregiver. So it's in very preliminary stages, but wondering if you had any thoughts or experiences with that. Thank you.
So briefly, about texting, absolutely. I have the same experience with calling and texting people, and there are a lot of people that are doing research projects looking at using texting to connect to patients. Most of that has been around behavior change issues and or reminders to come for appointments, I'm not sort of thinking of specific discharge instruction, but it certainly, that's one way of using a smartphone. I would just say that I think getting the instructions out there, it's usually more than a text, but the text could remind them, did you look at this link? You know, so you could certainly incorporate texting. Regarding audio and videotaping, I don't really know the answer to that. I would think it would be too long an audio or videotape for people to look at. So, you know, my just immediate non-scientific reaction would be that unless it's a 3-minute YouTube clip, it's not going to be useful. And if I watch those interactions, they're not, even though they may only be 8 minutes, but 8 minutes is a really long time. So that would be my concern.
Let me interject a follow-up from Linda Harris and myself as well on that smartphone question. Linda writes that you said most patients have smartphones, but does that mean they have access to enough bandwidth and data to have meaningful access to health information, such as monitoring, engaging education? And I just point out that a critically important aspect of that is who pays. If you want to.
So yes, I mean, so I agree that's an important point. I do think that most of my patients who are poor do access the internet on their smartphones, do use it in a sort of a reasonable bandwidth way. So I would think this would not overburden their use if these kinds of things would not overburden their use. But I don't have the scientific information to back that up.
Okay, great, thanks. Patrick.
Thank you. Patrick McGarry, American Academy of Family Physicians, Roundtable member. Thank you, Dr. Williams, for your presentation. I was really impressed with the discharge patient education tool. I thought I liked its simplicity, but I had a couple of concerns. One, and it's been alluded to already, is isn't it probably more important for a patient to know their prognosis versus their diagnosis? I think people at that point in time probably know pretty darn good and well why they're in the hospital and what was going on. But bear with me. And then further, if you look at the form, you talk about treatment. And I'm gonna, the question asks, when I was in the hospital, I was treated with, and fill in the blank. And I'm like, first thing that came to my mind, disregard or disrespect or something like that. And honestly, I'm speaking from experience here. I mean, not from my own personal, but from, family members and others. It's not a procedural issue. It's really an emotive type of response from their overall clinical experience or encounter. And I think, not to lose that point, I think it's very important that as you were talking about your hospital, wanting to make sure that from a marketing standpoint that you have happy patients, that's an important issue to kind of get into. How do they really emotionally respond to the clinical encounter? And I think we're losing it in procedures here. So that's my point. And I also want to say one quick thing. In regarding coordinating, especially in the PCMH level 3, AAFP is promoting a model called the Office Champions model. It's a coordinated care model where we designate a person within the practice to take the lead, and maybe there's beyond the physician, so it's usually a nurse or a respiratory therapist if it's in smoking or immunizations. We use it in that as well, and also in healthy lifestyle behavior. So there's a lot of merit to that in this whole health literacy process to use health coaches, I think it was alluded to earlier, and health educators. So I'd be remiss if I didn't mention that. Thank you.
Yeah, no.
The Office Champions model. In fact, you can Google it and it'll come up, AAFP Office Champions.
Well, good. Thanks for your comments about the discharge patient education tool. Because one of the things I want to mention is that, one, I think it's important that we should recognize and promote the healthcare provider as a filter on all of this information. And one of the goals of the discharge patient education tool was to allow that individual to filter the information so that it was manageable for patients. And when this kind of a tool was used with patients during the discharge, the patients actually felt that they were receiving the attention and the care provider cared about them because they were delivering the information in an understandable fashion and then using TeachBack to confirm the understanding. And I think I agree there needs to be a component that is given to the patients in an understandable manner that's organized, such as the discharge patient education tool. And then simultaneously, what I do when I take care of patients, and I've done this within the last year by myself, no residents, no interns, I give the patients their discharge summary at the time of discharge. I don't let them go until I've finished typing up their discharge summary, and then I have their discharge instructions as a separate piece. So that package goes with them, and then when they see their primary care provider, that information is there. And part of this came from Piedmont Hospital, which enrolled in the BOOST program, started disseminating the discharge patient education tool to patients, and they immediately started getting this feedback from two surprising sources. Maybe not surprising afterwards, but initially when I heard this, I was like, oh my goodness. One, home health nurses. They said, this is the first time we realized what happened while the patient was in the hospital. We were just sent out, we're supposed to see them and figure it out. And then two, primary care providers. They said, this is terrific. This distills what I really need to know about the hospitalization and the discharge instead of the discharge summary when I don't know when it's going to occur. And this was the instructions for the patient.
Great. Any other response? No? All right, Bernie.
By the way, Rima, I love that response related to the issue of having pilots. I think that was a great response. We ought to remember that. Mark, we really have a problem, and let me define my problem. We've changed the way we deliver medical care. Clearly, over the last 5 to 10 years, primary care docs don't go to the hospital very much anymore. That includes pediatrics, it includes internal medicine, all primary care, family practice, etc. That may not be true all over the nation, but it's certainly true in a variety of very important places where there's a large population, and perhaps even more important when it comes to safety net hospitals. So under those circumstances, where we're dealing with primary care, probably more in the way of elderly, probably more in the way of patients with chronic care needs, chronic conditions, it becomes imperative, really imperative, that we have timely transmission of information. And I don't mean timely, I mean real time. Now, it is nice to give I think it's a great solution, or part of the solution, to give the record to the patient. But suppose the patient doesn't come to see the doc for another 2 or 3 weeks, and in that interim of time, there is some critical element that occurs that needs the primary care's intervention. He or she at that time doesn't have any information. How do we assure, now that's not an easy answer, how do we assure that that timely transfer occurs? And has SHM made any efforts in that direction?
Thanks. I think this is a terrific question, and you raise a very important issue about which I feel incredibly passionate. From my perspective, we have got to take a global approach for managing patients as they're traversing this very dangerous transition from the hospital to home. And this includes things that have to happen in the hospital, including the primary care provider needs to know when the patient comes to the emergency room. The primary care provider needs to know if their patient is admitted to the hospital. The primary care provider needs to communicate with the hospitalist in the hospital, ideally with access to the electronic medical record, and be able to react to that. Lee Lindquist did a very nice study out of Northwestern where they had the primary care providers review the patient's medications while they were in the hospital and impact medication reconciliation, and showed improvement. Second, the primary care provider needs to know when the patient is leaving the hospital, and the follow-up appointment is set up within 7 days of the hospital discharge, so this link occurs. And I think there is, as you are well aware, there are now care coordination billing codes that allow some funding for that, and I think those are wonderful. I do think hospitalists are critically important to provide the 24-hour care that's now needed in hospitals. As you're well aware, hospitals are basically gigantic intensive care units at this day and age, and there, however, needs to be this hand-holding, as I like to refer to it, or a partnership between the primary care provider and the hospital-based clinicians as we're caring for patients. And if that isn't included in your organization's approach, you're absolutely right. We have a problem. But when that does occur, patients see that they have a team that they're a part of. And I think one other study I think it's real important that Lee Lindquist's research she did, she was checking up with patients, and this was an eye-opener for me, post-hospital discharge, and finding out that half of them were not compliant with their medication changes. The reason for that is they said, I need to check with my primary care provider first. And what I think ought to actually happen is that when I'm discharging a patient as a hospitalist, I've got an iPad in my hand. The primary care provider has an appointment on their schedule. They log into their computers, and this technology is available. It's FaceTime, or it's the other Microsoft's program. And you basically have the primary care provider pop up on the screen and says, hi, Mrs. Smith. I work with Dr. Williams. He told me about what's going on with you. I'm looking forward to seeing you Thursday morning at 10 a.m. Mrs. Smith is thrilled, and then we carry on the conversation. It's a very brief interaction I think would dramatically improve the quality of care, and I'm sort of waiting. Some hospital or health system is going to do this, and they're going to be wildly popular.
The market has to cover on the front end on admission and on the back end on discharge.
Yes.
And that communication piece.
Absolutely.
Excellent. Other comments from the panel?
Yeah, I'll just, I think your points are correct about the primary care provider's centrality to the process, but it's been challenging for us in particular. We've gotten pretty good at identifying who the patient needs to follow up with after discharge because we've made that a mandatory part of the discharge process, and we're able to do some mandatory things on discharge because we've got hooks into the EHR that don't let you let the patient leave until you do X, Y, Z, and because length of stay is such an issue, those things get done. However, finding the primary care provider on admission is something that requires just an act of good faith on someone to go ahead and do. The other aspect is that in my area, patients don't always know who their primary care provider is, which is obviously a huge problem in itself, or they're getting their primary care at a clinic where it's a resident who changes after 6 months or 2 years and somebody else, even if there really is an attending who's covering and responsible, the patient only knows the rotating resident's name. And you'd say, well, the EHR should manage that. The EHR should have a field that you put in who the primary care provider is. And that exists, but we've been kind of constrained from using it because the privacy folks feel that, okay, you had the primary care provider at the time the patient left the hospital. Now it's 2 months later. Are we going to trust that field to allow us to send information to this person? Maybe in the interim, the patient went to a different hospital and doesn't want that provider getting that information. They're not going to call back and say, please remove the PCP from my EHR field. They don't even know it exists. So there's challenges.
Yep, indeed. All right, we'll go Wilma, then Rima, and then I have Dr. DeWalt via email.
Wilma Alvarado Little, UAlbany SUNY, and a Roundtable member. My question goes back to, and I don't want to belabor it, but the question goes back to Terry Ann Parnell's question about the texting and Dr. Dwyer's response, and also Dr. Ng's. I'm wondering regarding that if there has been consideration regarding tapping a community that relies heavily on texting for communication as a way to provide guidance, and that would be the deaf community and the ASL, American Sign Language community, on what their thoughts are. It's been my experience as a hospital interpreter that, they rely heavily on texting, Skyping not so much because, again, as Linda mentioned, the bandwidth might be an issue. But if there's been any consideration in including them in any way to provide some thoughts.
Stump the panel? No.
Yeah, I'm stumped, but I'll say that. I'm not aware that, most hospitals do have access to interpreters for deaf families. So that is good now as opposed to years ago. But I'm not aware of any specific focus on including them in planning. And I think you're bringing up a really good point, especially about communication of any kind.
I'm not familiar with involving the hearing impaired either, but I think it's a great idea. We are doing some testing around using text messaging currently, mostly as appointment reminders, but beyond that, also reminding patients to sign up and then utilize their patient portal is another project that we're going on right now.
All right, thank you very much.
Thank you. I've been remiss in introducing myself. It's the power of an unusual name. I'm Rima Rudd from the Harvard School of Public Health. And this question is really for you, Mark, wearing your hat as the hospitalist. So we've been talking about discharge instruction. I wonder if there's an opportunity to sort of shift the focus a little bit and think about discharge preparation rather than simply discharge instruction. And so my former colleague, Lauren Daltroy, did a fascinating study in the late 1970s. Admittedly, things in hospitals were very different then. But while in the hospital, patients were prepared to take their own medicine. Medicine was left at bedside after the instruction by a hospital-based pharmacist. A nurse observed if they did or didn't take their medicine as prescribed, ready to intervene. And his point was that if hospitals persist in treating the patients as a child, doing everything for you while you're in, that the expectation that you could immediately transfer to an adult status and do everything for yourself was unrealistic. Now, a lot has changed since the 70s. Time is shorter in hospitals. But is there a potential for thinking about discharge engagement in a way and preparation?
You raise a great point. Two things. One, it's fascinating when you look back on the literature and look at other countries. You may have heard of something called the General Assessment of Preparedness out of, I think it's Australia or New Zealand, where they interviewed patients and asked them what did they need when they left the hospital and arrived at home. And lo and behold, they pointed out things such as, I need a way to get my medications from the pharmacy, these common issues. And two, I think what you're describing basically is simulation training. And this is what we should be doing, but there is such tremendous fear of lawsuits by hospitals that if they don't control everything, they're going to get sued more. And my firm belief in this, honestly, is that if we partner with patients and work to take care of them in the best manner possible, lawsuits will go down. You're absolutely right, though. There's such pressure to get patients in and out of the hospital. The system hasn't been set up to do this kind of training, but this is what's actually necessary. I went to a VA many, many years ago as part of IHI's Transforming Care at the Bedside initiative, and that VA was printing out the MAR, medication administration record, and giving it to the patients every morning so they could see the medicines they were getting. But I talked to nurses at some community hospitals. They were petrified at this concept that the patients would know when they were supposed to get their medicines and be complaining when they didn't receive them.
Just a brief comment. We do that in a very limited way. For example, I know that with new diabetics, parents and children, if they're old enough to be taking responsibility, there's a specific focus on having them be observed, learn how to do it, be observed how to do it, and be moved to that level that they are now responsible for themselves. And what you're saying is, why don't we do that for all patients? There's an obvious reason we do it for diabetics, because that's a very new and complex procedure for them to take over. But it's absolutely a good point that we should be doing that with all patients.
And they're doing this with these complex neonate cases that go literally from the intensive care unit to home, which has been stunning. And I was thrilled to see this article at the American Academy of Pediatrics. And I think pediatrics in general has taken leadership in this engagement of caregivers, parents, and children as we look at how we're transitioning patients from the hospital to home. But it needs to be applied across the spectrum of care.
As a by the way, Daltoy's study showed improved medication taking as a result and fewer returns to hospital. It's late 1970s.
All right, we have a couple more minutes. This is the last question, I believe, from Darren DeWalt. He says via email, a lot was covered by this panel. It would be helpful if Mark Williams, and I'll extend it to the rest of the panel to the extent that we have time, would summarize some key recommendations on where this should go now. A couple that Dr. DeWalt suggests are, we have some information on what patients want and need, but could get more information from patients on this. Number two, we have an implementation problem. Mark's work, reflective of patient feedback, still is not implemented very broadly. And number three, this is not just an IT problem, but we do have an IT problem per Mark's 7-year saga. So he's essentially asking you for further recommendations that you would make in this area in the next minute or two.
I think that there needs to be, in a way, support from hospitals engaging industrial engineers. That may be a surprising response, but we need to look at this as an industrial engineering issue of how do we integrate electronic medical records into the workflow of the care providers to best serve the patients. I think the EMRs came on the scene. You had individuals off in rooms far removed from care delivery, figuring out how do I do the best documentation. And there was not this pilot testing, because if there had been the pilot testing, they would not have been rolled out. I was at one institution and I almost fell out of my chair when they commented, whenever we implement a new component of the EMR, we first have the staff on the floor review it. If they say, no, this isn't functional, they stop the rollout. And that needs to be the policy pretty much everywhere.
Quickly, Bernard?
I think we need to either regulate or do research on patients' understanding of discharge instructions as we have now designed them. And what I mean by regulate is perhaps part of what we should be told is that we have to prove that patients do understand it before actually using a specific model of discharge instructions.
Yes, and we need to get providers back into the process. We now try to drive changes in healthcare by changing the EHR and expecting that when the provider turns on the computer, they'll say, oh, something's different, I'll do something differently, rather than going through the chairman and the chairs to the department heads to the attendings to the residents and changing the behavior of the doctors.
I think it's all about systems and getting all stakeholders involved in the planning and then the implementation, which is really through testing to make sure that the workflow works for the providers as well as for the families, who obviously need to be involved every step of the way.
Great. All right. Thank you all. One quick announcement. Lunch is right out the door for everyone, which is different for those of you who thought you were going to have to run somewhere and find food, courtesy of the Institute of Medicine and Lila Hernandez Magic. We have lunch for everyone, so enjoy yourself. We'll start back here at 1:30. Please thank the panel.